Explaining persistent pain using Pavlov's dogs, part 2 of 2. Thank you for coming back to the part 2 of this presentation. I hope that you have had a chance to visit the Pain Truth website and to download the Pain Truth app in order to learn more about the program. Let's briefly review what we discussed in part 1. Several explanations have been proposed for the development of chronic pain, which persists long after tissue healing. Classical conditioning or associative learning is one of the proposed mechanisms explaining the transition from acute to chronic pain. Classical conditioning can modulate judgments about whether an event is painful or not. Classical conditioning in Pavlov's dogs summarized. Neutral stimuli, the bell rings, no food is given, dog does not salivate. Then the food given, dog salivates. Then with repetition, ringing the bell, given the food, the dog salivates, and classical conditioning develops when there's no food given and the bell rings and the dog salivates. And the classical conditioning in humans with low back pain, there's bending, there's no actual tissue or injury, no pain experience. Then there is an actual or potential injury because of a trauma, heavy lifting, or whatever caused it, then you have a pain experience. Then with repetition, the movement that's identical to the action that caused the pain experience gets repeated. Then classical conditioning, where the actual injury resolves, or the tissue heals, let's say 2 years after a motor vehicle accident, however still bending results in a pain experience versus a conditioned response. Generalization, where no food is given, but the phone rings or the doorbell rings and the dog still salivates. Discrimination, when there's a knock on the door, which doesn't sound like a bell, but so the dog does not salivate. Extinction, after a long time when food is no longer given, when the bell rings, and you ring the bell lightly and repeatedly, but you don't provide food, the dog does not salivate. Eventually, extinction results in the elimination of the classically conditioned situation. In humans with low back pain, generalization, when there's no actual or potential injury, all movements and activities can result in a pain experience. That includes standing, walking, sitting, twisting. Discrimination is when lumbar extension or a novel movement, when there's no actual or potential injury, the conditioned responses, the unconditioned responses, no pain experience. Extinction is when graded exposure to non-threatening physical movements, gentle exposure to a non-threatening movement or physical activity, when there's no actual or potential injury, no pain is experienced. When structural injuries and red flags have been ruled out, should the management of chronic pain focus on eliminating pain? Modern medicine is obsessed with fighting and eliminating pain by using various modalities, creams, massage, manual therapies, and pharmaceutical interventions, from over-the-counter painkillers to opioids, which all inevitably fail in certain centrally sensitized individuals. These interventions are similar to focusing on eliminating the salivation in Pavlov's dogs, instead of focusing on elimination of the classical conditioning that has occurred. How should we manage a person's persistent pain? Option 1. Focus on controlling or eliminating the conditioned stimuli, CS, meaning all exposure to painful movements, which is not realistic in the long term. Perhaps in the short term acute or subacute stage it is, but certainly not in persistent pain cases. Option 2. Focus on controlling or eliminating the conditioned response, CR, which is, in this scenario, is the pain experience. However, that's obviously fails because that's the reason they are having persistent pain. They're no longer responding to medications, opioids, injections, various manual therapies provided by multiple healthcare providers, and various modalities used by various healthcare providers. Option 3. Focus on reducing or eliminating the association between conditioned stimuli and the conditioned response, which is what is proposed in this presentation. But how? Extinction by non-threatening graded exposure. Intentional and frequent graded exposure to specific movements and activities without fear and the exacerbation of the pain experience is the ideal method of eliminating the link between movement, CS, and the pain experience. Example, only partially bend forward every 2 hours and without fear for the exacerbation of symptoms. At first, the movement may need to be so small where the nervous system is not even sure if that was a real threatening movement or not. Extinction doesn't focus on eliminating the conditioned stimuli, such as the specific movement. Extinction also doesn't focus on eliminating the conditioned response, such as the pain experience. Extinction focuses on eliminating the associated triggers that are responsible for the pain experience. A few studies have experimentally induced classical conditioning among healthy adults. For example, in this study, modulating pain thresholds through classical conditioning. And another study published in the Journal of Pain, Pain by Association, experimental modulation of human pain thresholds using classical conditioning. In these studies, a vibration sensation, which was a non-noxious stimuli, was successfully linked with a painful nociception that later resulted in greater pain perception when the vibration sensation was perceived. Exposure to non-nociceptive vibrotactile stimuli was found to influence pain thresholds through classical conditioning. Classical conditioning could be a useful framework for understanding persistent changes in pain threshold that are not explained by the state of bodily tissues. A systematic review based on 13 studies concludes that the existing literature suggests that classical conditioning can amplify pain. Classical conditioning might evoke and maintain chronic pain. So now what? Once specific structural injuries and red flags have been ruled out, some individuals with persistent pain may be presenting with central sensitization that is maintained at least partially by classical conditioning. If an individual with persistent pain has been unresponsive to treatments focusing on pain elimination, example, various medications and manual therapies, or activity modification, example, by staying off work and limiting activities for weeks, months, or even years, then consider participation in the 6-week Pain Truth program. The Pain Truth program does not focus on the elimination of pain. The Pain Truth program does not recommend the elimination of aggravating physical activities or movements. The Pain Truth program does, however, focus on eliminating or at least reducing the classically conditioned association between physical activities and pain, based on neuroplasticity theories. The Pain Truth program focuses on pain neuroscience education, or PNE, to reduce the threat value of the pain experience. Patient-led goal setting. Motivational interviewing based coaching in order to empower the patient. Guided graded exposure to physical activities, feared and avoided. Addressing other contributing factors to persistent pain such as sleep, diet, stress, negative self-judgment, hopelessness, perceived injustice, and catastrophization. Pain neuroscience education to reduce the threat value of the pain experience has quite a bit of studies to back it up. This review presents moderate evidence that the addition of PNE to usual physiotherapy intervention in patients with chronic low back pain improves disability in the short term. Current evidence supports the use of PNE for chronic musculoskeletal disorders in reducing pain and improving patient knowledge of pain, improving function and lowering disability, reducing psychosocial factors, enhancing movement, and minimizing healthcare utilization. How about, is there evidence for patient-led goal setting? The study evaluated the efficacy of patient-led goal setting facilitated by a physiotherapist for individuals with chronic low back pain who were unresponsive to previous treatments. They were given a goal handbook and attended once every 2 weeks for 2 months, so a total of 8 sessions. Visits included neither manual therapy nor any specific exercise prescription. It's important to note that the patients in the study had greater improvements in their pain and disability scores than those in typical manual therapy or exercise-based intervention studies. If patients choose their own specific goals, they may have a greater sense of personal control over their health and be more engaged in dialogue with you about their life. Patients do not correlate well with clinicians' goals. A patient-led goal-setting intervention was significantly more effective than advice to exercise for improving outcomes in disability, pain intensity, quality of life, self-efficacy, and kinesiophobia and chronic low back pain. Is there evidence to support motivational interviewing-based coaching in order to empower? MI significantly increased adherence to prescribed chronic pain treatments. Is there evidence to support graded exposure to physical activities feared and avoided? Limited evidence has been found to show that graded activity significantly reduces disability in the short and long term. Let's go through case number 1 of a real patient that I just saw a few weeks ago. Mr. X presented with a 9-month history of low back pain and MRI confirmed disc bulge. He admitted to having a high fear of lifting, bending, slouching, and rotational activities. To further validate his point, any past attempts to bend forward and twist had resulted in worsening of symptoms. He admitted that there was a direct link between bending and twisting and the exacerbation of his low back pain. Hence, he avoided them at all costs. Classical conditioning in action. As a consequence, he had completely avoided all bending and twisting movements, as it had been recommended by various healthcare providers. However, when he sometimes accidentally bent forwards, his pain would flare up. Addressing the conditioned stimuli, meaning limiting movement, had failed. He had already tried opioids when his pain was severe, but was no longer on them. He was taking non-steroidal anti-inflammatory drugs and paracetamol, Tylenol a few times a week as needed. He had already received a few months of osteopathic treatments and spinal manipulations that had originally helped but were no longer effective. He was continuing to receive weekly massage, which at least provided temporary relief. Addressing the conditioned response to pain had also failed. Later systematic review on fear avoidance beliefs. Evidence suggests that fear avoidance beliefs are prognostic for poor outcome in subacute low back pain, and thus early treatment, including interventions to reduce fear avoidance beliefs, may avoid delayed recovery and chronicity. Week number 1. He was provided with brief pain science education, explaining that pain doesn't necessarily indicate tissue damage, which assured him. He was prescribed to sit naturally, comfortably, and without any lumbar support. He was assured that it was okay to sit slouched. If he felt discomfort, he was to stand up and sit down again and no longer focus on the perfect posture. He was provided with facilitations with movements into flexion to reduce his flexion dysfunction and his fear of flexion. So manual therapy is often indicated in anybody who has an actual dysfunction. He was prescribed self-flexion exercises in sitting 5 to 10 times every 2 hours for 1 week to reduce the threat of flexion. The home exercises were all to be performed short of pain and certainly not be perceived as worsening his condition. After 2 weeks, he was provided with star mat clock lunges and twists, with education that end range pain was okay as long as it didn't exacerbate his symptoms. He was also prescribed clock lunges with partial flexion and rotation. After 4 weeks, he was provided with star mat clock lunges with full flexion and rotation into multiple directions. then clock lunges with flexion, rotation, and lifting into multiple directions. The patient attended once every 2 weeks. After 6 weeks of consistent graded exposure to non-threatening, relaxed sitting, flexion, rotation, and lifting, his low back pain and fear of flexion was resolved. Addressing the association between movement and pain was successful, at least in this scenario. Certainly that does not happen in every case, and this was one of the better success stories. Case number 2. A young soccer player with a 2-year history of right posterior thigh pain presented with a diagnosis of chronic hamstring strain. He admitted to having a high fear of running and sprinting activities. To further validate his point, any past attempts to play soccer, sprint, or even run have all resulted in worsening of his symptoms. He admitted that there was a direct link between playing soccer, running, and the exacerbation of his hamstring pain. Classical conditioning in action. As a consequence, he had completely avoided all running activities and playing soccer, as it had been recommended by various healthcare providers. However, when he sometimes attempted to do even a short run, his pain would flare up. Addressing the conditioned stimuli, limiting movement, had failed. He had already tried NSAIDs and various topical creams with little benefit. He had already received a few months of physiotherapy treatments focusing on soft tissue release techniques and stretching and eccentric strengthening exercises, and that had originally helped but were no longer effective. He had also received a few months trial of treating his lumbar spine and pelvic misalignments, which also provided no relief. Addressing the conditioned response, the pain had failed. Can hamstring pain in athletes be centrally sensitized? This study compared professional athletes with persistent posterior thigh pain to pain-free age, sport, body mass index, and level matched controls. They found that athletes with persistent hamstring injuries display impairments in their cortical representations. It was shown that their injured legs present with tactile, proprioceptive, and left-right discrimination deficits. Perhaps chronic posterior thigh pain in athletes with non-resolving hamstring injuries may be related to central sensitization and cortical changes rather than just the hamstrings. He was provided with brief pain science education explaining that pain doesn't necessarily indicate tissue damage, which didn't really provide much assurance to him. He had been told for the last 2 years that his hamstrings were torn, his hamstrings were strained, his hamstrings were injured, there was scar tissue in his hamstrings were too short, were too weak. Everything was related to the tissue-based model of pathoanatomy. And here I come along and tell him, perhaps it's not your hamstring muscle and your tissue. It caused cognitive dissonance. And it takes a bit of therapeutic alliance building before he can accept the new idea that it's not perhaps a tissue-based problem. He was prescribed a 1-minute jog on the spot to do 3 to 10 times a day and assured that it was okay to feel mild discomfort as long as the discomfort reduced back to his baseline by the next day. He was prescribed with leg swings for dynamic hamstring stretching without any provocation. Leg swings were to be done with both eyes open and closed in order to maximize proprioceptive awareness of the affected lower extremity. He was prescribed a 10-minute mindfulness meditation that focuses on full body scan, but with increased awareness of the affected region of discomfort. He was to no longer focus on fighting or eliminating the pain, but to be more accepting and understanding of his symptoms. This meditation is available on the Pain Truth website or the Pain Truth app under the section Mindfulness. He was provided with a graded exposure to a jogging program, starting with 2 minutes and increasing by 30 seconds each day. After 3 weeks, he was prescribed a home program to casually kick a soccer ball around for 3 minutes. Ideally, play with a child in order to make it fun. He was to gradually increase the time by 1 minute every few days, as long as it was non-threatening. His previous attempts at playing soccer involved going back on the field and playing full force with his fellow colleagues. However, that was too much, and he was already classically conditioned and associated playing aggressive soccer to pain. Hence, we wanted to begin with a fun activity like kicking a ball around with a child. Based on ongoing pain science education, he was now aware that if his symptoms flared up, he was not to fully rest, but to reattempt the activity within 1 to 2 days, but at 50% intensity, and begin again. He was shown the video, Good Pain versus Bad Pain, that is available on the Pain Truth website and is available on the Pain Truth app. After 4 weeks, he was provided with star mat clock lunges with full flexion and rotation in multiple directions. Then clock lunges with flexion, rotation, and lifting in multiple directions. To maximize proprioception, the exercises were to be done with both eyes open and eyes closed. This is to influence proprioception and neuroplasticity more when the eyes are closed, because greater body awareness is required. With 8 weeks of daily consistent graded exposure to non-threatening running and playing soccer, his hamstring symptoms significantly improved, where he was much more optimistic about recovery. Addressing the association between movement and pain was successful. In summary, addressing classical conditioning requires pain neuroscience education to reduce the threat value of the pain experience. Patient-led goal setting, what do they want to achieve? Motivational interviewing-based coaching in order to empower the patient. Guided graded exposure to physical activities feared and avoided. And, as required, addressing other contributing factors to persistent pain, such as sleep, diet, stress, hopelessness, perceived injustice, and catastrophization, or maybe depression. The 2 case studies that I reviewed here, neither of those people had any of those contributing factors. Therefore, recovery was pretty smooth sailing. However, if people have all these other contributing factors, such as stress, hopelessness, perceived injustice, catastrophization, poor sleep, or diet, recovery may be slower, even when classical conditioning is addressed. Please visit the Pain Truth website or download the app in order to learn more about this program and access the videos, which are all freely available for patients to view. If you have any questions, feel free to personally contact me. Thank you.